Okay, so I'm going to be talking about the stroke and musculoskeletal system. I'm not going to be showing the videos on the recording because I'm on my laptop and everyone is in the audience and on the regular computer, but for some reason I could not get the audio to work. So the videos you can watch on your own. You may probably hear some of the sounds from the videos when I'm playing them on the regular screen. And then this, the PowerPoints will be in Mesa as well, if you wanna look at them yourself. Okay, so a stroke. So we know a stroke is also called a cerebral vascular accident, also known as a CPA. So typically what happens from a person that has a stroke is because there's some area of their brain that's not getting perfused. Right? So we have something obstructing, whether it's the carotid arteries, maybe it's one of the arteries within their brain. There's something obstructing the entire brain from getting perfused. And so that could be a matter of one or two things. So we could have a clot. We can have a clot form in the area, or we can have a clot travel from somewhere else, or we could have an aneurysm that could burst and cause a hemorrhage or a bleed. So these are some things that I had looked up yesterday. I have always just known FAST. That's just always been the mnemonic that I've known. So typical symptoms that you're going to see when your patient comes in: facial drooping, one arm hanging down, speech is slurred, and then you need to call 911. Time is of the essence with our patients that have a stroke. So there isn't time to like question, oh, I'm not sure what should I do. Maybe I need to go get someone to help me and figure out what to do. Like, it's an absolute emergency, and quite honestly, at the time of it happening, the time clock is ticking. So we have like for a clot, we have like a 3-hour window that we could possibly reverse the stroke. And what that would be is giving a medication. We're not going to talk about it, called TPA. We're going to learn more about that when we get to nursing 205. But it's basically like a clot-busting medication that can be given for a patient that has a clot. And so basically it thins the blood and it tries to dissolve that clot. Now, obviously, if a patient was bleeding, so we have to figure out, we have to determine first before we can give the medication. Is this a clot or is this a bleed? Because if it's a bleed, we can't do anything about that. But if it's a clot, we could give them TPA. So time is of the essence. You have a 3-hour window. The first thing you always want to do when your patient comes in is ask them, when did the symptoms start? If they don't know, then quite honestly, most of the time the TPA is kind of out of the window because we have no idea. Maybe the symptoms started overnight. Maybe they started when they were sleeping. Maybe they didn't even notice that they had symptoms because maybe they have things like diabetic neuropathy, that their nerves are already damaged. Or maybe they have like MS, multiple sclerosis. So their nerves are already damaged. So that they might not feel if they start to have a facial droop or their arm starts feeling a little tingly. But if they know exactly, so anytime that you're with someone and you start to notice these symptoms, the first thing you should do as you're calling for help is to look at the time, because the time is really important. So FAST has always been the one the American Heart Association, American Stroke Association has always put out. Then I found these other ones, Be Fast, that's really cool. So it's same FAST, but it's also talking about balance and eyes, because sometimes you can lose vision in one or the other eye, and sometimes you can lose your balance, which is why we're going to talk about musculoskeletal assessment too. And then the other one is faster. So your face, your arm, we have the same. Stability is kind of like balance. Talking, so would be the slurred speech, eyes, and then to react. So they kind of all mean the same thing, but they're a little different for words. Be fast, faster. So this is what you're expecting to see your patient coming in with a stroke. These would be like a classic symptom. So you're the nurse working on a med surg unit. You just received a report on your 6-patient assignment and begin your day. You walk into your patient's room, and upon introduction, so you're walking in, good morning, my name is Cassandra, I'm gonna flip the lights on, and this is what you see. I wish I had my popsicle sticks. So what would you do? What's your next step? Anyone? Question how long their face has been like that. Would you say, how would you say that? Not like that. Okay, so how would you say it? How else could you say that? How else could you say that? I'm sorry? You could ask them to smile. What else could you do? How else could you ask them about their face? Yeah, Gabriella. Okay, that's a good question. Have you ever experienced drooping, right? Because we don't want to shock the patient, right? So, hey, good morning, my name is Cassandra. When did your face start drooping? Right, that's not the best that's not the best introduction. So, good morning, my name is Cassandra. How are you feeling today? Are you noticing any like numbness, tingling anywhere in your body, right? So you're generalizing questions first to see what the patient's feeling. Then they say no. Then your next question should be, or your next statement could be, so what I'm seeing is I see that you're exhibiting some facial drooping. Is that something that you've experienced before? So rather than saying, oh my gosh, you have facial drooping, have you had that before? It's more what you see. So I see that you are showing some facial drooping. Is that normal for you, or have you ever experienced that? And so then that's a no, and then that's the moment that you should immediately activate some sort of code, rapid response, whatever your facility is. We call them code strokes. So sometimes it's just like a rapid, but for some reason it just prioritizes it, and when they call it over the speaker, code stroke in whatever room, it does stimulate some other people to come. So what other people would you expect to come to a stroke? Yes, a neurologist. So that's, who else might come? The doctor. So the doctor's always going to come, right? The rapid response team is always going to come, which would typically be like your ICU nurses. Who else usually comes to like a regular rapid response or a code? Who could you think? I'm sorry? Cardiologist might come. Who else? Yeah. Respiratory is going to come. Who else do you think would come? Maybe surgery, depending on the scenario. A lot of times they're called in after because we're not really sure what's going on. Who else do you think might be called? Yep. Yep, so maybe like an EKG tech, a phlebotomist. Why would an EKG tech be important to come to a stroke? Monitor the heart. What could be going on in the heart that could initiate a stroke? I'm sorry? Maybe a blockage, yep. What else? I'm not expecting you to know it, but I'm just putting my feelers out there. Maybe they have an arrhythmia, right? So maybe they're having an arrhythmia that formulated a clot and then that threw it somewhere, right? And that put it out to somewhere. What else could a patient be exhibiting that could put them at risk for a clot? High blood pressure, so maybe they're hypertensive. We could look at that on the monitor too. Maybe they're in these fatal, really fast tachycardic rhythms that you're gonna learn about in nursing 5, but we can look at that. How would you react? Calmly. How else? Okay. Quick. Yeah, so absolutely quick. So this is so the difference between a stroke is a neurologist typically needs to come. A lot of times too, a speech pathologist will come too, because we want to then assess, is the patient able to swallow their own, just for basics, swallow their own saliva. Because if there's something obstructing, right, so thinking about that, our face is drooping. So we have affected our nerves in our face. So thinking about our face, our head goes right into our neck. And so a lot of times that can affect our nerves in our neck too, which could affect our swallowing capabilities. And so what would the patient be at risk for if they couldn't swallow? Aspiration. We want to look at their airway, right? Because if their throat is if they can't swallow their spit and they're just kind of like building that up, they might not be able to breathe appropriately, right? We're not getting our oxygen. So there's a couple different types of stroke that I want to show you. So the most common is an ischemic stroke. So that occurs when a clot, so this is straight on the American Stroke Association. An ischemic stroke occurs when a clot or mass clogs the blood vessels, cutting off blood flow to the brain. Typically, the underlying condition is development of fatty deposits lining the blood vessel walls. So thinking about this, when we're doing our carotid assessments, what would you expect to hear maybe if you had a patient at risk for stroke and had some clot buildup or some fatty deposits that could be building up the blood vessels or the artery? A bruit. So that's why we listen with the bell of our stethoscope on our carotids, and we talked about that in the cardiac assessment. So why do we do that? Because if we have a blood clot like this, we have all this fat deposit, all this yellow buildup on the side, that's going to create a swirling effect of the blood, because the blood is trying to fit through that little opening when it's used to fitting through this bigger opening. So it can create a bruit, and you can hear that on our patients. So this is what it would look like typically if your if your brain is being perfused. And then as you can see, now we're gonna, we clotted off this area. So if I go next, now you can see this area here is not getting perfused. Whereas a hemorrhagic stroke, so this is what an aneurysm may look like. It kind of balloons in our artery. And so what happens is our patients end up bleeding because of this, because this balloon ends up rupturing. So we may have one up in here. There are a bunch of different locations. We have one affect, some of them can affect our optic nerves too. So then that's going to affect our vision as well, which is why then our patient loses maybe vision in one or both of their eyes when this happens. Too many mice. And then we have a transient ischemic attack, which is also called a TIA, or also called, some people call it a mini stroke, and it usually is caused by a temporary clot. And so thankfully, a lot of TIAs resolve within an hour, but again, if we're having symptoms of that, it's going to put us at risk for actually having a stroke at some point in our life. We'll talk about a little bit more on TIAs, but typically ischemic strokes account for at least 87% of the strokes that actually occur. So typically it is formed by a blood clot. So who can tell me, what does the term atherosclerosis mean? Narrowing out the arteries from what? Yep, plaque. And then, so we have narrowing of the artery from plaque, and then we have an embolism and a thrombus. So what's the difference between an embolism and a thrombus? Because they're both clots. Yes. One is mobile and one is not. Which one is mobile? An embolism. So we have an embolism that forms somewhere else and then it travels. So where would an embolism form? The heart, a vein. Where else? Lungs. Where else? And your carotids too, right? Because we just talked about that, fat buildup. Versus a thrombus is something that is going to form right in that location. versus a hemorrhagic stroke at most 13% of stroke cases. There are different types of hemorrhages. There are aneurysms, arteriovenous malformations, and they can be intracerebral. So I can show you what an actual hemorrhage looks like. So this would be the difference. So we have this patient that has a scan. So typically we have patients initially come in and we do a CAT scan or a CT scan immediately of their head. And then, however, there is, and I don't have the actual percentage, but there is a percentage of CT scans that don't pick up a bleed or a clot. And so if the provider reviews the CT scan and doesn't really feel confident about the scan and the results of the scan, the patient immediately will go into an MRI. And so typically what the American Heart Association suggests is that within 15 minutes, the patient is getting a CT scan once they hit the emergency room. So that's why when we're on the floors, our patient's scheduled for a 9 o'clock or a 1 o'clock CT scan and it gets pushed back, it's because someone else is a priority. And at that moment, that patient would be a priority over my patient on the floor that's just waiting a bladder, or a chest CT or something, I don't know. Because we have to meet a certain criteria in order for us to be a stroke accredited facility. So typically they say about 15 minutes upon the patient walking in the door and check-in, we should have them getting a CT scan. And so if we get a CT scan, the provider is not confident in that, we'll go get an MRI. An MRI is going to be a lot more indicative and actually it will actually be able to pick up a bleed. So this is what you can see this dark and I'll shut the one right now. So why would you just do an MRI? They cost a lot of money and they take a lot of time. So a CT scan is quick, like in, scan, out. An MRI it can take up to half an hour to do an MRI. We only have one MRI machine where we have 3 CT scans. So it's just a little quicker. And sometimes they just on a CT scan, they come up and they're really easily read. It's sometimes like our patients that maybe are exhibiting like a lot of symptoms, or they're not staying still when the CT scan is being done, but that's typically the reason. So you can see here, this is the actual bleed. So if I was to give my patient TPA, this medication that we're going to give for this patient over here that doesn't have a bleed, I was going to give it this, what do you think would happen? It's going to keep bleeding. This whole area is all blood. And what it's going to do is it's going to create that area to continue to bleed all through the brain, which is irreversible. All right, why is this now? Why is this not playing like this one?
Aneurysm is
and only a small percentage of that group will experience a rupture. People who have a family history of aneurysms, have polycystic kidney disease, connective tissue disease, and people who smoke are at increased risk of rupture and should consider screening. If a rupture happens, fast treatment can save lives. For the Mayo Clinic News Network, I'm Vivian Williams.
figure that out before I show you the rest of the videos. So again, looking at our brain, we have our dura and then our arachnoid, and then we can have something called a subarachnoid hemorrhage, which is kind of like in between that area, and it's really hard to, because of an aneurysm, whether it's like an optic from an optic nerve or more of a internal cerebral artery formation, and they're just, as you can see, it would be very difficult to fix that location. So we have a TIA, like I was talking about, a temporary blockage. So typically symptoms last from 60 minutes or less. They can also go away very quickly. So it does not cause permanent damage. However, the biggest thing that people will say is, I had a stroke and it disappeared. And they don't understand the prevalence of that. So if there's obviously something that there's typically some sort of embolism or thrombus that's affecting the blood flow to that area. And so what typically would happen is, if it's a thrombus, our arteries may kind of find a way around it and actually then reperfuse that brain. But it doesn't mean that that thrombus isn't still there. Same thing with an embolism. An embolism might have clotted that certain area, but then the blood flow had continued to move around and kind of relocated that embolism somewhere else. So there's still a problem. It's just whether the actual clot stayed or it continued to move, or maybe it dissolved, or maybe it was just small enough that it kind of blocked it, but then it didn't block it, type of a thing. So the biggest thing to remember is that with TIAs, yes, the symptoms will go away, but it does mean that they're still at risk for now having a stroke. So a TIA happens before about 15% of all strokes. Up to 25% of the people who have a TIA die within a year. And about 1/3 of people who have a TIA have a severe stroke within 1 year, because again, there's still a problem and we haven't figured that. If we don't figure that out, then that's an issue. So what do you think are some risk factors to patients having a stroke? What do you think you would like, diseases or assessments or risk factors to a patient having a stroke? Anyone? We talked about some of them already. High blood pressure, hypertension. What else? Diabetes. Kidney. Smoking. What else? Obesity. Maybe medications. What else could put someone at risk for having a stroke? Stress. Age. Maybe a family history. What else? If they had a TIA, yeah. Exercise, maybe. What else? High cholesterol. Yeah. EKG check in there? Maybe arrhythmia? Yeah. Maybe your diet, yep, because right, we're gonna have high cholesterol, so our diet could put us at risk.
Like heart diseases.
Yeah, like coronary artery disease. What other heart diseases? Yep, peripheral arterial disease, heart failure, maybe an MI, right? Heart attack. So did you know that people who have diabetes are 1.5 times as likely to have a stroke than people that don't have diabetes? I just want to figure out why sound doesn't work. Hi. Huh? Oh, we'll go there after. Oh, I shut it off. I don't know. Not frequently. It could, I'm sure, but I wouldn't say that the prevalence of that is like frequently, would be frequently. Oh, there we go.
Every 2 minutes in the United States, an adult with diabetes is hospitalized for stroke. And while 26 million American adults have been diagnosed with diabetes, an estimated 9.4 million have diabetes but don't know it.
When you have type 2 diabetes, your risk to have a stroke is higher than for people that don't have diabetes. In fact, it's about 2 times as high. When the blood sugar is high over time, unhealthy changes happen in the blood vessels. With this can come plaques and blockages inside the blood vessels, and when a portion of the brain is not able to get the blood flow it needs, that's when strokes can happen.
People with diabetes and prediabetes are at increased risk for stroke, but they can live long, healthy lives free from heart disease and stroke by taking steps to stay healthy and control their risk factors.
The good news is diabetes can be managed and the risk for stroke can be lowered. I tell my patients who have diabetes who want to lower their stroke risk that first of all, they should pay very close attention to following their medication regimen exactly, but they should also identify other risk factors that they may also have that can be associated with that increased risk of stroke. Most important of all, I want them to become aware of lifestyle changes that they might make that would significantly lower their chances to have a stroke in the future. Some of these are targeting an ideal weight, targeting a good amount of exercise, and eating a healthy diet.
In addition, taking steps like not smoking, limiting alcohol, and learning to manage your stress can have a significant impact on your overall health. Talking to your healthcare provider can help you manage these factors and help you stay on track.
You should really make yourself aware and teach your family too about the signs and symptoms of stroke. Strokes in people with diabetes look just like strokes for people who don't have diabetes.
Use FAST to spot a stroke. If you experience face drooping, arm weakness, or speech difficulty, call 911 immediately. Additional symptoms of stroke can include numbness, confusion, trouble seeing, trouble walking, and severe headache. Having diabetes increases your risk of stroke, but it's important to remember you're not alone. If you have type 2 diabetes, talk to your healthcare provider and visit stroke.org for more information.
So I want you guys to take 5 minutes. I'm going to break you into pairs. I'm going to add a category up here. And what I want you to do with your pair is I want you to determine what kind of teaching points would you use for whatever category you're assigned, and how would you present that maybe to your patient that's at risk. So you have maybe a patient that has hypertension, or a patient that's obese, or a patient that has high cholesterol. How would you apply, like how would you talk with them? How would you teach them about the importance of that? So Helen and Molly, you guys can do healthy weight. Molly and Victoria, you can do exercise. Firda and Matthew, you can do eating healthy. Barat and Jitendra, you can do smoking. Ruth and Gabriella, you guys can do use of alcohol. Did I already do that one? No, I didn't. Use of alcohol. Barty and Kirsten, you can do stress. And then Allison and Marissa, you guys can do medication administration. So take 5 minutes to figure out how you would teach it, and then we're gonna all talk about it after. Yes. I meant to say Jenna, sorry. No. Helen and Molly, you guys are doing healthy weight. Jenna and Victoria are doing exercise. It's probably because I was just looking at you. Yes. Oh, it's okay. And then I moved to my calendar. It's okay. No, I just, yeah, no, when I was looking for the future, some good videos or articles or something in different areas. Yeah. It's just all flat. So there's like a lot of space to spread out. No. How are we going to work that? Yeah. Yeah. Okay. Yeah. Oh, good. Nothing. Everyone's very different. Right. You guys ready? So talk about healthy weight.
And then also not working out at the gym, but just like going on a walk once in a while.
Food and exercise. So how would you approach that for a patient that let's say is obese and doesn't work out at all, lives in a low socioeconomic status location and is unemployed?
I feel like you would have probably like little changes in like avoid red meat or like salt and stuff.
Okay. So how would you say that? How would you do that to your patient?
Younger, less meal, like what? Like, I don't know, salad. Chicken?
Okay, you could do maybe like a lean meat instead. Maybe instead of having it on a bun, so that way we're worried about carbs, we can put it on a salad and have all the same maybe toppings or condiments on it. So it seems like they're eating maybe like a chicken sandwich, but it's just not on the bun, right? Something like that. What about John and Victoria? What about exercise?
When you're trying to pick up the family stuff on your phone, you want to, swimming, walking, if they are, in a low economic, environment, they, just in their house, they could walk around their house, and even just to keep like moving, moderate intensity, we want to avoid any high intensity or, impact, like, or anything like that, reduce stress.
Good. What about Matthew and Pierre? What about eating healthy?
Yeah, our goal is to be talking about that diet, low cholesterol, low fat. But most importantly, it's a diet that you want to sustain for the rest of your life. So it's not going to be something you'll be on for like 1 or 2 months to like lose weight or something like that. You want to start making it a healthy habit. To talk with the patient about like, making slow incremental changes to develop a better lifestyle. I think before, and like they were saying, using veggies as a side instead of fries, or using salmon instead of that hamburger, So they're talking with them about that, and you're going to
I'll be more about thank God the food pantry, they have now fresh food veggies, so you really can have that rotation to take food diet. And for diabetes, really have to like, just try to eat snacks, all those options.
Yeah.
Instead of
Looking at that pre-diabetic nature, especially because that goes hand with your diet too. So just make sure you communicate the dangers of diabetes as well. The
We can think about too, maybe initiating if they like to garden, that you can grow tomatoes on your back porch, even if you're not in a location that you can actually make a garden, but you could still do small changes, also making sure we're keeping in mind size and portion. So maybe not totally eliminating all the things that they like to eat, but just making sure that we're doing it like good portion sizes. For example, someone really likes to eat chocolate ice cream before the bed. They go to bed. That's just a generic thing. They're used to doing that. That's just the way that they end their day. Doesn't mean we have to totally get rid of that. We can change it out for maybe like a frozen yogurt that tastes the same as a chocolate bar, but it's a little different. Maybe we can look at dark chocolate instead of, you know, a bag of Reese's or something like that. What about Baratin Tender? What about smoking?
So smoking constriction of the blood vessel, which increases hypertension, and become a plastic with double-digit chance of ischemic stroke. And so they would have to decrease their smoking or cessation of smoking. They would have to manage their medications if they have any. Definitely exercise some diet and management of stress.
Do you think it'd be appropriate for your patient to stop? What if they smoked 2 packs a day of cigarettes? Do you think it would be appropriate for them to just cut cold turkey?
You know, therapy they go to the training with those groups.
Yeah. Go to a group, support group. Good. What about use of alcohol?
So that increases the risk for immediate delay. So some alternatives to be excessive drinking would be to find drinks that still have like that flavor, maybe like a non-alcoholic, a seltzer, an occasional soft drink. Talk to your family and friends, let them know that you're coming back so that they can give you that support. Not like they don't even alcohol. And if you are in your drill, you're running a piece these are also things that help you to somewhat reduce your intake of alcohol and
Good. What about stress?
stress. And healthy diet too, because you're eating healthy, your body's gonna feel better. I eat like crap, I feel more joyful.
Yeah, absolutely. So even like breathing techniques, giving yourself a moment to collect your thoughts before. Yeah. So, and then being mindful as we're kind of going into medications that they don't have, you're talking to your provider too, if you're on a bunch of medications and you start taking up over-the-counter and herbal supplement that can interact with your prescription. And then what about medications?
We said like education, and it just explains to them like the importance of taking it and why they're taking it, the side effects that they're going to have, if they take it, how they're going to feel better, and then also telling them the effects of not taking it.
Mm-hmm.
So we just said like educating them on like the importance of it.
So back to our patient. So what assessments would you conduct for your patient? Now we've talked about risk factors, we talked about some signs and symptoms. What assessments would you conduct? All right, you call the rapid response team, you call a code stroke, they come in, they evaluate it, they determine the patient has stroke. They send them down for a CT scan. They figure out and it's an ischemic stroke. They bring them back up. What assessments would you do now as the nurse? A neurological assessment, okay. A musculoskeletal assessment. What else? What parts of a cardiac assessment would you want to do? We want to listen and see if they're the regularity. Well, we're going to look at their blood pressure, so maybe do some vitals. What else? Assess their breathing. We could look at capillary refill, determine if how they're perfusing. Right? Yep. Range of motion exercise, Helen. Mm-hmm. Mm-hmm. Right, so we might want to do an eye assessment to assess for if their pupils are equal, round, reactive to light, and they're accommodating. We want to look at their orientation status, right? Because one of the symptoms of a stroke is confusion. So we want to see if they know where they are, what's going on, what their name is. We want to do a cardiac assessment. Maybe we want to auscultate our carotids to see if we're hearing up or weak. Maybe we want to do a mouth and respiratory assessment to determine if their airway is patent and they're breathing. They don't have some, we want to look at their saliva and their mucus production. We might want to do a musculoskeletal assessment. I wish I had my popsicle sticks. Ruth, you want to come on up, and Kirsten, you can be her patient. So I do have part of the validation up here. So why don't you go ahead and show us how you would do an eye assessment? That's okay. I have the answer right here. Okay.
The shape.
We'll try to do it a little without that. See what you can remember from our discussion last Wednesday.
And then that's for like moving, involuntary moving.
Okay.
And look for any drainage from the eye.
Okay, we're gonna look for drainage.
Yes, the color of the pupil, the iris.
The iris, the color of the pupil. Yeah. What else?
And the light reflection.
We can look at the light, the reaction,
That's the pupil reaction of the light.
the pupil reaction to light. How are you going to do that?
Well, by light.
Okay, by shining the light into their eyes. Okay, I don't have a pen light. We're going to practice in the lab though. Oh, there you go. Jenna has a pen light.
Then I'm just gonna just follow my hand.
Victoria, come replace her.
So you can one where you hold the light and if it's like
Maybe. That's okay.
so I would lift the upward and I roll down
Okay.
and then I don't know.
What are you looking for?
And see if the arm's moist, if there's any discharge.
Okay.
Or, and then we'll do it for the lower back up. I will look at the color.
Okay.
If it was pale.
Maybe. Yeah.
I then would help me and look for the
Okay.
And then, configuration, the second one where I don't know. Rigid. What I look inside, see if she looks me. When can you see me?
Would you do it from the front?
No, the back.
Okay.
When can you see my hands? Sorry. The Ischemic would do. to
Okay.
see color.
Okay.
I would do, the eye test, I cover an eye and see if she can see,
What are those tests called?
I can't. What was it, Mom? And some.
Snellen. What's the difference?
One is for nearsighted, and one is for farsighted.
Which one's which?
And the Rosenbaum is for farsighted.
Is the close-up one, right? The Rosenbaum is the close one, and the Snellen one is the 20 feet away.
I like opposite.
Opposite words, though. Yeah.
And then the reaction to light would be what you went in and out with the light.
You guys are good. Yeah. What else? What else are you can go sit down. What else, Molly? Yeah. Yep. The 6 cardinal. What are you looking for in the 6 cardinal positions of gaze? Okay. Do you remember the term for that? Maybe they have nystagmus, or their eyes drift.
So
Drifting. Yeah.
when I'm doing like the 6 cardinal phases for each nerve, or I would just start differently.
No, you would just say for cranial nerves 3, 4, and 6. Oh, they're all together. They're one test. Yeah. Right. Your pupils were equal, round, reactive to light, and accommodate. Something really important when you're doing, when you're determining if your patient's reactive to light is to shine it, but don't go across, because now you're gonna stimulate your other eye when you don't want to. So you wanna kind of move it into one eye, maybe turn your pen light off and come over here and then turn it back on and go across, or maybe like come down here, so that way the light isn't going to affect the reaction. Lacrimal apparatus, right, or right up in here. Remember when we were talking about making sure our eye drops don't go into our lacrimal apparatus? So one of the things that we might want to do too in assessment is a musculoskeletal injury or a musculoskeletal assessment, because maybe their stroke is now affecting their balance, right? We talked about that for BFAS, right? Balance, gait. So maybe they have some sort of pain in their joints or in their arm, or maybe they have some weakness. What does paresthesia mean? To Helen. Okay, yep, like pins and needles, Jenna. Numbness and tingling. So we would maybe see that when, where would we see that with our patient that has a stroke? Maybe in their face. Where else? Arms, maybe in maybe their leg, one whole side of their body could be like that. What's paralysis mean? Loss of muscle movement and sensation. So again, our stroke patient might have paralysis on one side of our body. What's pallor mean? Pale. What would that have anything to do with musculoskeletal? Lack of blood flow or lack of perfusion. So maybe we can determine that there's something blocking that area. So maybe they have an embolism in that area that's affecting their blood flow. What about a pulse? What does a pulse have anything to do with our musculoskeletal? I'm sorry? Maybe they have a low pulse and they don't have enough blood. What else would you be assessing with a pulse, Barty? They might not have a pulse at all, so maybe they have a blood clot. What else? What are we looking at? The 3 things we look at when we assess someone's heart rate. Maybe they have an arrhythmia, right? So it's irregular, which could have put them at risk for a clot. So yeah, Matt. So I would probably say I would probably still palpate it one at a time. Usually though, if they're at risk for an aneurysm, it's something most of the time we're a little bit aware of. And a carotid aneurysm, you would most likely see a lot easier. Maybe not for your overweight or obese patients, but you probably would see some sort of like a growth, or this area might be bulging. You might see a pulsation in that area, so you wouldn't touch that at that point. Yeah, because your carotid is it's not deep under the skin, so it's very superficial. It's very close, and so you would typically see if there was a giant aneurysm, you would most likely see that pulsation. So some things that we want to ask them, maybe a health history, some common complaints. How have you been feeling lately? How do you walk at home? Do you walk independently? Do you use a cane or walker? How do you perform your ADLs? Any grating sounds? Or maybe when I squat, right, my knees pop, or like sometimes I'll move my ankles or my toes and I can hear them popping. Are they on any medications? What are their medical diagnoses, like gout, cancer, TB, arthritis? Yes. It's important to know why is that happening? Is that something that's normal for them, or is that something that's new? I think that would be the more important aspect. Some people just do forever and it never affects their musculoskeletal assessment. Sometimes it's just a little air pocket. Yeah, mine usually do. That's why I squatted. I expected mine to, but they didn't. Bye, thank you. Do they have a history of osteoporosis, blunt or penetrating trauma? Do they use assisted devices? What medications are they on? What's their personal habits? You want to determine what's abnormal. So what's their baseline and what are they coming in with? So maybe they have something new that's going on. Their ADLs, you're going to assess their central nervous system. So we're going to do a neuro assessment, which we're going to learn about next week, and a musculoskeletal system. We're going to inspect and palpate everything. So our musculoskeletal system, think about our skeletal system as our whole body. So we're looking at our muscles and we're looking at our joints. And so we're going to go everywhere. We're going to start at the top and we're going to move our way all the way down. You might need a tape measure just in case sometimes our patients have a longer limb than the other. And obviously you can shorten or focus your assessment. You wouldn't have to do like head, neck, shoulders, elbows, wrists, fingers, hips, spine, knees, ankles, toes, if they're just coming in with complaints of their legs. Probably not really going to be appropriate to do like a shoulder and head assessment if the reason that they're here is a lower extremity assessment. So it's important to generally inspect your patient first. Like, what do they look like? You're going to see if they have like redness or swelling or bumps or bruising. Maybe you can see that they're using a cast or a splint or a boot or something. We want to do head to toe, proximal to distal, right? So I'm going to start head, neck, shoulders, knees and toes, head, neck, shoulders. Then I'm going to move down to my elbows, to my wrists, to my fingers, to my hips, to my knees, to my ankles, to my feet, and then lastly, you're going to do your spine. You're going to look, so if you were to look at your musculoskeletal assessment, which I'll show you at the end, it's the exact same thing for every single joint. So every joint you're looking at the muscles, you're looking at the size and the shape, you're inspecting all the joints, you're palpating all the joints, you're palpating the skin around the joints to see if you're hearing any like crepitus. You want your patient to then move your joints. You're never going to force a movement. So sometimes our patients that maybe have MR, they may be contracted, or maybe they have a neurological situation going on that they're contracted. So they're like this, right? And so when they're like this, you're not going to force their arm to open because you quite honestly will most likely break something. You typically should not be, unless your patient is demonstrating some sort of like paralysis, that they're physically, their arm is flaccid and they can't do anything. At that point, you're going to kind of move it a little bit to see what you can do. But in reality, the patient should be moving all their joints. You shouldn't be doing that because you don't really know exactly what their joint, how it works. So if I'm used to going like this, like flexion and extension, and I say move my arm like this instead of extend, I could do something to that joint. So you don't want to do that. You don't want to physically manipulate the joint. You want the patient to, as most as possible, be able to do that. Ask about pain. You can tell, obviously, if a patient's wincing, if that's really uncomfortable. We're going to look at how our patient stands and moves. We're going to observe their gait or how they're walking to see if they're steady. These are just a couple pictures, right? So flexion and extension. I always remember adduction is you're adding your arms back to your body. So you're adding it versus adduction, yes. I just like the spine last just because like trying to have your patient bend over, that's a lot of exertion. So it just might be really uncomfortable then to have them finish. So why not just do all the regular joints? The spine is a little different because you're actually having the patient fully bend over like this to look. So why not just go through all the regular joints and move them all as you would and then do the spine last? Just makes mental, it makes, I guess, you could do, sometimes people will do the hips and the spine together. I've always just done the spine last usually. So you have pronation and retraction. We have eversion versus in. So think about inversion, elevation, depression. Some of you, if you were to look at me, I was seeing it here, you can see that this shoulder is shorter than this shoulder. So that's why you would maybe use like a measuring tape or something to determine if there's a change. We have circumduction, rotation, we have supination, pronation. Obviously there are a lot more, but this is just a picture that I came up with. So head, neck, and jaw. So we're looking at our face, we're looking for symmetry. We're gonna look for TMJ. So that's important when we're doing our head. I want my patient to open their mouth. I wanna see, do I hear clicking? Does it hurt? Is there a lot of pain? Yes. Yes. Yep. Inspect the front, back sides of the neck. Palpate the back of the neck right in your spine to see how that feels. We're looking for range of motion. So thinking about it, I can look up, I can tuck my chin, I can look side to side, and I can rotate. Right, so that's a lot of different movements. You're gonna wanna test all of those movements for the head, neck, and jaw. Same thing with shoulders. We're looking for symmetry. We're looking for, again, our patients that maybe our clients come in, they're like big, beefy, muscular. We want to note that because if they're really, really big here and they're really, really tiny here, that's important to note the symmetry of their muscles. We're going to actually palpate our shoulders, right? I'm palpating my neck too. I'm going to palpate, you're touching every single joint. So I'm going to palpate my shoulders. Looking for bony landmarks, again, crepitus, tenderness, or again, so I can up, down, I can go forward and back, and then I can rotate, right? I can go out, adduction, adduction. So there's a lot of movements with our shoulders. Elbows, same exact thing. If you're looking at this, right, so I can rotate, and then I can flex and extend. I should be able to move it up to 90 degrees. If I can't move my arm, my elbows up to 90 degrees, that's an issue. And then again, wrists and hands, we want to make sure we're being careful of our patients that have osteoporosis or are elderly. When they're very fragile, we want to look for redness to determine if they have any sort of arthritis. We want them to move, right? To be able to determine if they have full movement. Same thing with our fingers, right? Flexing and extending. Our fingers, wiggling our fingers, we want to see that full range of motion. And a lot of this is what you're doing when you're assessing and doing stroke assessment on your patient. You're determining what their strength is, what their movement is of all of their joints too. So we're looking at our hips, we're determining symmetry, right? I want to make sure that they're both the same. I want to know if they had hip surgery or hip replaced. That's important to know because that may limit the amount of range of motion. Remember, I can move my hips out like this. I can go forward and backwards. I can kind of rotate, right? I can I can bend, I can really move. So that would be if you wanted your patient to bend, that could be a time you could look at their spine at the same time if you wanted to. You're really looking at this area, right? Your actual hips. You want to make sure you're not feeling any like crepitus or popping or anything like that. And then kind of moving into the knees, we want to have them walk. So how do they walk? Because if I walk like this, that's kind of important, right? Some people, so actually my stepbrother got in a really bad motorcycle accident many years ago. And his, after surgery, he has like his one foot is this much shorter than the other. So he has to get risers in all his shoes. So if he would not have shoes on, he does not walk steadily at all. You're going to also want to look at the position of their knees, right? So sometimes our patients kind of are bow-legged, right? And their legs go out, or they're knock knees like this, and this is how they walk. You want to be, and again, like pigeon-toed too. So you want to look at that as well. Do they need some sort of an assistive device? You want to palpate their knees. Again, moving knees. You really can kind of rotate, I guess, your knee a little bit, but yes. So that would be when you were assessing your, when they bend over. So you would just like hold your hands here and feel it. Yep, you would hold your hands and you have your patient bend over like this. You would be able to look and see if there's one hand up like this, and that's a problem. Yeah. And then ankles and feet, same thing as wrists and wrists and fingers, right? So I can rotate, dorsiflexion, I can inversion, eversion. So I can do a lot with my feet. And then same thing with my toes, I can flex and extend them, and I can wiggle them. And then muscle strength. So as you're going down through, you're also determining muscle tone. So we're determining if our patient has some sort of paralysis or atrophy, so they're not maybe able to. So again, one of the things that he also now exhibits is he has atrophy in his right arm. So sometimes he can't even move it. Like it's totally flaccid sometimes, and then he'll regain the strength. It waxes and wanes, not all the time. So that's important to know if you're sometimes really strong and sometimes you're not. You can assess that you can assess muscle tone by also like pushing and pulling. So how did your patient put your hands? If I was putting my hands up here, Kirsten, go ahead and push your hands, not your hands, push against mine, right? And then pull, grab a hold of my hands and pull back. And I can have you straighten your arms out for me. And lift up against my hands and pull down. Right, I can do that with the legs too. So lifting and pulling, I can push like I'm pushing on a gas pedal, and I can pull back. So you want to determine what their muscle strength is. You can put your hands on either side of their head. Tell them to hold their cheek in. You can see their muscle strength of their neck. I already talked about observing their gait. So again, I'm typically going to want my patient to walk farther than like 3 steps, because that's not really going to give me a good observation of their gait. So I'm going to want them to walk. I want to see, are their arms moving with their legs? Are they jimping? Are they steady? Does it seem like they're like all over the place? Because maybe there's something hemodynamically unstable, like out of hemostasis why am I saying hemodynamic? That's not what I want. In their ears, that could be causing them to have something like vertigo or dizziness. Equilibrium, thank you. That too, maybe they have like weakness or something on just one side of the body that can make them do that. We can also have patients have a lack of equilibrium within their ears. So if your ears, and that's something we didn't really talk about, but if we don't have equilibrium within our ears, it can cause you to become dizzy, lightheaded. It can also cause vertigo. So that could happen. So just being mindful of, what could be happening. And then again, our spine. So we're looking at our spinal process. I'm going to have my patient stand and bend over and just dangle their arms like this. And then I'm looking at their spine. So I'm looking to see if you see that S curvature, scoliosis. And then I'm also going to look when my patient is standing upright. for the difference between kyphosis versus lordosis, okay, and how that looks versus normal. So what labs would you expect to find on your patient when you're assessing your stroke patient? What labs are you looking for? Calcium, phosphorus, when we're looking at musculoskeletal. What other labs are we going to look for? Potassium. Why are we going to look at potassium? See if it's low or high. That could be causing them to have an arrhythmia. What else? Looking up there in our list of risk factors. What other labs are we going to look at? Sodium, glucose, cholesterol, creatinine, GFR, UN. Okay, so platelet. I realized I never talked about that, but I'll talk about what I do. What's the normal sodium? What's the normal potassium? What's BUN? What's creatinine? What's glucose? So now we're also going to look at our calcium level. So we can look at calcium. Typically, our range is from 8 to 10. It's a cation, so it's a positively charged, and it's found in the extracellular fluid. So a big part of calcium is coagulation, transmission of nerve impulses. So again, that's why it's important when we're doing a neuromuscular assessment to assess their calcium. We want to look at component of bones and teeth. And typically it's best absorbed if we add vitamin D. So a lot of times you'll see a lot of foods that have calcium are fortified with vitamin D as well, because it helps the absorption. So some hypercalcemia causes, maybe we have cancer, maybe we have something wrong with our thyroid, versus hypocalcemia would be inadequate intake. Maybe we have some sort of reason for excessive calcium loss. There's a lot of different symptoms up here that are kind of hard to follow. So I kind of made this new little mnemonic. So when we are hypercalcemia, we have high amounts of calcium, our body is really weak. Right, so we have weakness of muscles, we have EKG changes, we have absent reflexes, and we have kidney stone formation. Versus our patients are hypocalcemic, they end up having cramps. We have confusion, hyperactive reflexes, arrhythmia, muscle spasm, and a positive trosuit sign, which don't worry about that, you'll learn that later. It was an S too, which I got rid of because we don't have to do the S yet either. But cram was just it didn't help. Yes. Yep. I'm gonna probably post a study guide for now, and then when we come back during that clinical, we'll do that. Also, yes, your sterile field is going to be postponed to the following week, and the following week it's going to be Wednesday, Thursday, and Friday. So I would tell you to be mentally prepared to do it on Wednesday, because we're going to have some time on Wednesday that we can start knocking some of you out, so we can stay longer in clinical on Thursday and Friday and not come back at 10 o'clock or 10:30 to do all the sterile fields. And we're just going to select you. I'm going to have the popsicle sticks. I'm going to pull your name and you're going to come. So please be prepared for Wednesday. I will give a demo. We will give a demo in person when we come back, but the videos are on my YouTube and that has not changed. So they're all there. That is exactly, we didn't give demos last semester, we gave the videos and that was it. We never showed a demonstration or anything like that. So the videos are on YouTube for putting on sterile gloves, removing sterile gloves, and setting up the actual sterile field. So please watch those, and you have all the components to practice in your red bags that you got, other than the cups, the bowls, which we'll give you later. And then we'll give it to you today. Yeah. And then when we come back, when we are supposed to do sterile field, we will just give you a quick demo and post conference, and then we'll have, so be prepared to have to have that validation on the 14th, 15th, and 16th. And I'm going to send an email out so that's clear for you guys too. But be prepared that your card might be pulled on the 14th to do sterile field. Yes, yep, for the test too. So I'll probably just post the study guide, and then when we come back, I'll just do like a review. Like we'll actually take like 30 minutes. The post-conference will be focused on doing a review for the test on the following week and doing a sterile field. That'll take up probably like an hour of post-conference.
Okay. So our patient has kidney stone formation. What labs would we expect here?
Correct, and a BUN, right? Because if we have a kidney stone, our kidneys are going to try to get rid of that. So they're going to be under stress, so our BUN and creatinine might be elevated. What are we going to do as a nurse if we determine our patient has a kidney stone? I'm sorry? We're going to want them to increase their fluids, right? So that we can maybe try to initiate urinating that out. What else? We maybe want to get their pain under control. What's one more thing? Yeah. Maybe we want to change their diet. A kidney stone is going to be coming out. What do we want to do? Put a hat in the toilet and strain the urine, right? So we're going to want to make sure that we collect that because sometimes that gets sent down to the lab and it gets tested as well. Our patient has weakness or confusion for both hyper and hypocalcemia. What precautions are we going to implement? Fall precautions, right? We want to make sure our patient isn't getting up and walking on their own. So we have EKG changes and arrhythmias. Now what labs are we looking for? Potassium. What are we looking for with the potassium, high or low? It could be both, right? We remember that murder and what was the hypokalemia? Anyone remember? The 5 L's. Right, so we can determine that EKG changes are happening, whether it's high or low. So we're going to be looking for that. Jenna, why don't you come up and Kirsten, oh, you're a patient. Gabrielle, you can be a patient. This is like a very big, I intentionally made this kind of like adding a bunch of stuff for the whole semester. So if you are lost, you have a lot to catch up on over the next few days. Because if you're not remembering any of this stuff that we're talking about, you're really behind. So go ahead and do a cardiac assessment.
Or investigation, I would probably feel on her arms, check her color and see if she's clammy. I would check her hands for maybe some edema. I'm going to check her capillary valve. Check her single hands. I'm also going to check her pulses bilaterally. Pulses are strong and they're equal bilaterally. I'm also going to check it. So I would check her legs, see if there's any edema, and check her color, bruising, and that. Doesn't clam me, everything's good. Okay, so I'm going to do my assessment. I'm going to go to my bell first, the cardiac hemorrhage. Start with it. Okay, so I just did the aortic. Now I'm doing the pulmonic. Down to Earth's point. the tricuspid. I would do the mitral. I would also inspect the mitral, the apical pulse, see if there's any pulsations. And this is at the midclavicular line. So I'm going to switch to the diaphragm. And listening to the pulmonary first. Or, sorry, aortic. So I just wanted this sort of present, any murmurs or anything abnormal.
Inspect and palpated color, temperature, texture of the skin, hair distribution, apical impulse, palpated capillary refill, palpate pulses, so the pedal pulse too. Yep, so making sure you're doing that. And then edema everywhere, and then you did the 5 cardiac landmarks. One thing I'm going to tell you guys to do, so that way if you guys can go sit down. Good job. If you're having a hard time like talking and putting the placement at the same time, it's okay to say, okay, so I'm going to listen to all 5 my cardiac landmarks. Before I listen, let me tell you where they are. So because you do have to tell me the location and the actual name of the landmark. So you have to say in your validation, aortic, second intercostal space, right of the sternal border. Pulmonic, left of the sternal border, second intercostal space. Third intercostal space, Erb's point, 4th to 5th intercostal space, tricuspid, and then mitral is 5th intercostal space, midclavicular line. So you do have to verbalize that at some point. And if it's easier for you to just say it out loud and then actually do it, that might be just easier for you. Instead of like trying to say it and listen and talk at the same time. Yeah. So you can just do that because we just have to mentally see that you know the location and you know like where you're putting your stethoscope. Because you can do this all day long, but if you don't know where that location is, that's the problem. Yeah. Nope, you can just say it once like that and then just listen to your diaphragm and your valve.
And do we have to say like, I mean, I said color and everything, but
Yep.
should I say equal hair distribution? Say that's color.
Yeah, I would definitely say like majority rules. So I mean, if you miss like one, you wouldn't like get a no on that section. But if you only say, if I was to go back here and say you only said I palpated the color and you never talked about temperature, texture of the skin, or hair distribution, you'll get a no. You won't meet that criteria. Majority has to rule. So obviously majority would be more than half. So you'd have to at least say 3 out of the 4 of those to get that section criteria. So then reflexes. So how would we assess if our patient had absent reflexes or hyperactive reflexes? Yeah, with the hammer. Yep. So I have them in my video, but they're in the neuro assessment. So I pulled these ones because I know you guys like her anyway. So.
And in this video, I'm going to show you how to test the tricep deep tendon reflex. So let me show you how it's done. Okay, now we're going to test the tricep deep tendon, and it is located on the back of the arm, right above the elbow.
And notice it's really important. She's using the pointed end of the hammer on the tricep.
Right above the elbow, that deep tendon.
Called the olecranon process.
So we're going to go ahead and let it go there. And this is going to check C7 to C8.
You don't have to know.
What we're going to do is we're going to take the hammer and just briskly hit on that tendon. And what you'll see is extension of the forearm and slight contraction of the tricep. So here we go. Okay, so that is how you check that deep tendon reflex. Now, check out my other videos.
You know, no one has ever done that. Before I didn't know if that was the same. That's never happened.
So typically we don't do that one often in practice. A lot of times, like when you go to your doctors, they do your patellar reflex, but it does give us an idea as to what's going on in your body by doing, again, if we're going to do our lower extremities, why are we not assessing our upper extremities too? So notice with the patellar, she's going to use the flat side of the hammer. So there's the pointed end that she used for the triceps, and then she's using the flat end.
And that is where you're going to go. Okay, after locating the tendon, you put your hand to support it, have them relax.
If you hit the kneecap, it's very painful. So make sure that you're not doing that.
Okay, so that is how you check that deep tendon reflex.
Oh, it's like right in the way. This is like way too tight here. So you're going to want to assess that too if you're looking at calcium levels as well. Phosphorus, 3.5 to 4.5. I'm going to tell you, phosphorus also you're looking at for your renal failure patients. I don't want you to really get too deep, and I don't have a lot of stuff like I did on calcium about phosphorus because I want you to have an idea, like kind of albumin. I want you to have an idea of like what it is and what I do want you to know the lab values to determine if it's high or low. But I don't want you to really focus too much on actual like what you do about it, because a lot of this has to do with stuff you're going to learn in nursing too inside as well. So it's not really appropriate. But some things to think about with phosphorus, it's an acid-base balancing. Electrolyte, it promotes energy storage, carbohydrate, protein, and fat metabolism. So it can be looked at when we're looking at our nutritional status, bone and teeth formation, and our muscles and our red blood cell function. So again, sometimes high phosphorus levels are because the kidneys aren't getting rid of it. Kind of like potassium. Potassium elevates because our kidneys aren't getting rid of it. Same thing with phosphorus. Does anyone know what the term tetany means? Yeah, I'm sorry. Like muscle tension or like contraction, huh? Spasms. Yep. So you're going to see that. You're going to also see that with calcium too. You always go back to the calcium slide. It was on there. Back behind before I made the mnemonics. You can see tetany is up here too. So you're looking for that as well for these imbalances, especially. Anorexia, again, nutritional weakness, so muscle weakness, tachycardia, again, with hypo. A lot of times our patients have ketoacidosis, we're not taking it in. Sometimes diuretics can make it low because we're getting rid of a lot of it. Same thing too with DKA, because what are the 3 Ps? Polyuria, polydipsia, polyphagia. So polyuria, again, we're urinating out a lot when we're in DKA, so we're going to be getting rid of all of that phosphorus. So what interventions are you going to do with your stroke patients? What are you going to start doing with them? Huh? Nursing interventions. What nursing interventions are you going to do? Your patient has a stroke. So maybe you're coming in after this whole event has happened. Maybe it's like 2 days later. What are the nursing interventions that you're going to be doing with your stroke patient, Helen? Therapy, physical therapy, occupational therapy, speech therapy. What else, Gabriella? Maybe we'll do some reflex testing. What else? Fall precautions, huh? Monitor intake and output, yep. Evaluate if they can do their ADLs. I think this is on, I'm pretty sure I posted this on Nathan. If I didn't, I'll make sure it's up there. There's 2 screenings that you're going to be doing on your patient. If they do have a stroke, one of the interventions that you're doing is a dysphagia screening. So you're determining if your patient can swallow. There are multiple different types of dysphagia assessment or swallowing assessment. The one that we use at St. Peter's is we ask them to do a bunch of things before we actually give them water to drink, because we want to make sure that they're able to set themselves up, talk to you, they know where they are, they're not confused, they're able to hold the cup, like all those are components to being able to eat and swallow as well. And then once they pass those, we actually give them some water and have them drink it. And then once they drink it, we want to see, can they clear their throat? I want them to talk, so usually I'll give them my water, and then I'll say like, and then when you're done drinking it, tell me something funny, or tell me something about yourself. So they'll drink it, and then they'll usually say like, this is the dumbest thing ever, which is totally fine, because I don't care what I'm hearing for, is I'm hearing if they have, sometimes, you know, when you swallow and you can kind of hear the gurgling in your voice, I need to know about that, because that means that they didn't physically fully swallow all that water. I want to know if they're drooling and some of the water is coming out. I want to know if they're coughing and trying to clear their throat because it went down the wrong tube. That's a muscular change. So those are a lot of the questions I'm looking for. And then the stroke scale is a very long and extensive assessment. It's looking at neurological assessments. It's looking at your muscle assessments that I was just showing you. It's asking you to talk and say a few words, kind of describe a picture. It's doing a pupil assessment to determine if they can accommodate. So it's kind of so take a look at that just to give yourselves an idea of what that looks like. But again, some other nursing interventions, positioning, right? So we're going to be turning and positioning them every 2 hours. We're going to be giving them incontinence care, just like our skin precautions, because again, we don't want them. What if they have total paralysis on one side of their body? Are they going to feel that their arm is just laying there in the same position? Are they going to be moving it if they have full paralysis and it's flaccid? Are they going to be moving their arm on their own like we would? No. So if their arm is just laying here and their side is just laying here because they don't feel that it's going numb because they don't feel it, we have to be able to move them. We want to make sure that they have range of motion, active and passive. We want to do I's and O's, skin assessment, maybe speech therapy. Personal hygiene is huge. Sometimes your patient may require a walker or a cane going home. And so how to teach them with your cane or your walker. So there's this mnemonic. Cane is the opposite, so whole. Cane is opposite of your affected leg. So my affected leg is my left leg. So my cane is going to move with my non-affected leg. It's going to be on the same side as my affected leg because thinking about it, I need to put pressure to maintain balance, but I'm going to be moved up. Now, so you're right. So it has to be on this side because you're not moving this leg. So you need something to stabilize when you move this, and then it goes with your affected leg. Opposite affected leg. No, I always do with affected leg.
It's in place of your leg that's not working.
Oh, right. But the cane is the opposite of your affected leg. Yes. Yes.
Because essentially, if you think about it, your cane is not that you ever would, but if you duct tape your cane to your affected leg, you are using that in place of the leg that's not working.
Right.
So your arm is working in place of the leg that can't hold pressure. The arm and the cane is in place of the leg that's affected.
Does that make sense? It's kind of confusing. And then walker is with the affected leg. So you're moving the walker and then you're moving. And then you're moving the walker, kind of like crutches too. And so these are some walkers and canes. They're all different. Some of them have a straight handle. Some of them are single point. Some of them pivot. Some of the walkers, we have just a regular walker. We have a front, if this had 2 wheels on the front, that would be a front wheel walker. We have like these little devices. If someone has like difficulty or can't even move this leg, we can put our knee up on here and we can kind of roll around. So there's a bunch of different types of walkers, just to be mindful of what kind of a walker. our patient might need. So again, I want to pair you with your groups again. And Molly and Helen, I want you guys to look at clopidogrel and aspirin. So I want you to determine if your patient, why your patient would go home. Your stroke patient, why would they go home on clopidogrel and aspirin? I'm only going to give you like Jenna and Victoria, tramadol or hydrocodone. And I want you to tell me like what does the medications do? The mechanism of action or the indication. Matthew and Fearda, cyclobenzaprine. Jitendra and Barat, simvastatin or atorvastatin. The three of you in the back, Ruth, Gabriella, and Barty, blood thinners, and then the three of you up here, azetamine. So why would your patient go home on these? And how do they work? What's the mechanism of action? Yep, for your stroke. Why they go home on this? Yep. So clopidogrel and aspirin. Why would a patient go home on clopidogrel and aspirin? Okay, so decreasing the risk of clot. Why tramadol or hydrocodone? Yep, so muscle or nerve pain, right? Our patient could go home with pain from the effect of extremity. Why cyclobenzaprine? So muscle spasms that could alleviate those symptoms. What about simvastatin or atorvastatin? Called what? Yep. So what are these medications though lowering? On lipids or cholesterol, right? So cholesterol or lipid lowering. What about a blood thinner? Why would a patient go home on a blood thinner? Anticoagulant, so it prevents blood clots, or we can make sure that our blood is nice and thin. What about azetamine? Yeah, no, I did. I've always called it Zetia because that's the trade thing. But lowers cholesterol, so it can prevent arteriosclerosis or another stroke. So inhibiting platelets, so clopidogrel and aspirin, there's a lot of research that's been studied that both of those together combined actually lowers our risk of stroke. Again, pain relief, muscle relaxant, cholesterol lowering, prevention of blood clots, and cholesterol lowering. So looking at these, so we have our blood thinners and our clopidogrel, also called Plavix. Our blood thinners are things like warfarin, the trade name is Coumadin for that, or Eliquis, Brilinta, Xarelto medications that you see on the TV. So what would we teach our patient about if they're at risk for bleeding? What are some bleeding risks that we would teach our patient about? Falls, so reducing the risk of falls. What else? I'm sorry? Yeah, being careful when you're preparing food in the kitchen. What else? Nosebleeds, bruising, shaving. A big thing that we forget about is a soft toothbrush, because if we're really scrubbing on our gums, that can initiate bleeding as well. We want to make sure that they're looking at their stool. What would their stool look like if they were bleeding? Black and tarry, right? So we want to make sure we're telling them that. If they're outside, we want to look at what do they do in life. Are they an outdoorsy person? And we need to tell them, when they're outside, they need to be more careful. And you need to maybe hold pressure for twice as long the time as you usually think that you would to make sure that bleeding stops. Yes.
I noticed that a lot of patients that do the discharge that I was almost all of them were on baby aspirin.
Yeah.
So like,
That's different. Baby aspirin is a little different. Your baby aspirin is not going to initiate as big or as much of a bleeding risk as like a full aspirin 325 or any of the other blood thinning medications. But usually, yeah, typically it can be, sometimes it's a combination medication. It kind of depends on what's going on with that patient. They might just take that every day because that's what a lot of like the older generation, that was the thing. Like you took an aspirin instead of a Tylenol or an ibuprofen. So it could be related to that. Could be related to cardiac disease. Sometimes patients will home on a baby aspirin, but you would definitely still want to teach them about bleeding risks. So, I mean, they're still on an aspirin. It's just a small amount. So the risks are going to be less on that than they would be like any of these other ones. Inhibiting clopidogrel and ezetimibe. A big side effect that's in red is also angioedema. And so what do you think we're going to assess for if our patient has angioedema? Swelling, skin, of their face, of their breathing. So Matthew, why don't you come up and show a lung assessment on Allison? Just a regular, not the whole card.
Hand hygiene, cleaning gloves and everything like that. I'm going to start my respiratory assessment by inspecting the patient. I'll be looking for signs of like using accessory muscles when they're breathing. I'm listening for signs of wheezing or any difficulty, distress in breathing, shortness of breath. Are you feeling okay? Okay, make sure the patient's in a nice comfortable position. And I'm also looking for color as well too, just to make sure there's no differentiation color on the chest or anything like that too. Just kind of assessing the patient in that regards. Once I've done that, I'm going to lightly palpate the patient on their lungs and on the back, feeling for any lumps, swelling, masses, or anything like that, or just pain or tenderness as I'm pressing on them. So sorry, I can't do it. I'm just going to lightly feel here any pain, tenderness, swelling. I'm going to feel the back too, just to get rid of those spots, make sure there's no lumps or masses. Everything feeling okay? Okay, so once that's all set, I'm going to use the eye-turn stethoscope. And we're just going to listen and exploration on the chest as well. So every time my development or the diaphragm stethoscope touches your chest, just take a nice deep breath for me. Okay. And this would be a good time to also listen to their breathing, see how much they're inhaling and exhaling as they go through this process too, listening for any adventitious sounds such as crackles, bronchi, anything like that as well. So you can go ahead and inhale. And we're just going to move along the chest here, listening to those lung sounds. And your placement may vary depending on the size of the patient. Just going to go down. Go down and around. Perfect. Big shift at the sides too. Perfect. And just in case they were listening, they have like any type of lung surgery as well. You're just listening for a function for those ones. So I'm trying to begin on the back. Perfect. With the back here, you're going to be avoiding the shoulder blades. You want to make sure you're listening to the lungs. Awesome. Okay. Are you doing any like any business? Right. Thank you. And then,
Good.
thank you.
Good job.
So our patients with pain medication or also our simvastatin and torvastatin, a big side effect of that is constipation. So we want to really be mindful of like when are their bowel movements, what's their baseline, so we can keep track of that as well. Marissa, why don't you come up and Barney, you can be your patient. I don't have a table, so we'll just do it here. I swear we're almost done with this and we're gonna look left. Okay. So I'm gonna go ahead ranking. Go ahead and introduce myself, I'm Marissa. I'm gonna do an abdominal assessment. I'm going to look at her abdominal from 2 different angles. I'm gonna look and make sure there's no lumps or masses on it, and then I'm gonna go on this side and see if there's any hernias or any like fluid buildup or anything. So then I'm going to palpate in the 4 quadrants, starting clockwise, unless she has any pain or you experience any pain. Okay. So I'm going to start here, and I'm just feeling for any tenderness, any lumps, anything like that. Do you have any pain at all? Okay. So then I'm just going to then. Actually, I have a question. Am I doing like the knocking part? I don't know. You that's the part that I don't remember. Okay. So then, see if I hear any active vowel sounds.
Down.
I thought that was a mouth. Sorry.
So I hear active vowel sounds. And then I would do the yeah. So I would put my 2 fingers in and I would knock and see if I have any like. Sorry. So I know you can
Yep. Yep. So looking for symmetry would be like 2 angles. You're looking at the 4 quadrants to determine symmetry too.
So I would have to say I'm looking for
Yeah.
equal symmetry.
Yep. What else? anyone else have something to say?
Yeah.
Go ahead, reach now.
Yeah, no, that, you know, I did out of order. As soon as I started listening, I was like, oh.
So don't do that. What did I tell you guys? Instant fail. Like there's no correction for, oh my gosh, I realized I did that wrong. There's no correction for that. So if you automatically start by palpating and then auscultate, and then you get to the bottom and you're like, oh my goodness, I was supposed to, you can say it all you want, but it's still gonna be an automatic fail. Yes. There is no verbal correction for that. Who wants to say? Yep, go. Peristaltic, good. What you gonna say, Gab? You don't want to rupture anything. Good. So you want to make sure you're accepting contour from two angles. I'd like to pair 1 and 3 together because they kind of are very similar. So I'm looking for contour from 2 angles, and when I'm assessing the contour, I'm also assessing for symmetry. Make sure that my abdomen is symmetrical on one side or the other. One side isn't bulging or the other. I'm looking for the skin for hair color, scars, and bumps. And then I'm going to listen. And what kind of bowel sounds am I going to listen for? What are the 4 types? Hyperactive, hypoactive, normoactive, absent. So they have to be those words. That is proper use of medical terminology. And then light palpation for guarding, tenderness, masses, motility. So something that you might have seen when you were looking at simvastatin and atorvastatin, the cholesterol-lowering medication is a really big side effect. An emergent situation would be rhabdomyolysis. And so I usually don't talk about this, but I feel like since I've been really pushing you guys to like do meds and we're talking about musculoskeletal assessment, why not talk about it? So what this is it's a direct or indirect muscle injury. So muscle tissue breakdown results in the release of a protein called myoglobin. And then myoglobin ends up damaging the kidney. So when our patients are on cholesterol lowering medications, we're always going to be looking at their kidney level function. Because if we start to see dark red in urine, oliguria or anuria, and full on muscle weakness, they might be exhibiting rhabdo. We just usually call it rhabdo. That's just the typical nursing medical abbreviation. Everyone just says rhabdo. Patients at risk for rhabdo. So what are you going to do? Biggest thing is you want to relieve those kidneys of all that stress of trying to get rid of the parts of the medication that's causing this muscle injury to occur. And so our kidneys will then take all these proteins that are being released from the muscle damage into our bloodstream and try to get rid of that. But that's really toxic to our kidneys. And so we want to make sure at that point you would give a lot of IV hydration to relieve the kidneys of all that stress. And so this is our neuromuscular assessment. I kind of combined them intentionally. And so you're going to see here inspecting and palpating the size, the contour, the color, the skin, the muscles, the range of motion, the strength, and the crepidus of all of the following joints. Shoulders, accessory nerve, which is shoulder shrugging, and strength in turning our head side to side, which is what I showed you guys, neck, head and neck. Elbows, wrists, hands and fingers, hips, it's a C because you have to palpate the alignment and have them bend over so you can see the alignment of their hips. Spine, knees, ankles and feet, your feet. You're doing your triceps and patellar reflexes, and then pain and light touch. So we use pain and light touch to determine if a patient has some sort of nerve damage that's causing them to have like tingling sensation. So what you would typically use is something sharp and something else. I'll show you in the lab. Usually we use, oh, I have a pencil. Pencil. So what I would do is I'm going to break my patients down. Arm, 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 right? Arm, 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 arm. So I can have numbness here. This is going to be different than this. Maybe there's a blood clot here. So arm, 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 arm. Leg, 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 leg.
You can divide the face into 4 or 3. It really kind of, or 4 or 6. It really kind of depends on the size of the patient's face. I would say 1, 2, 3, 4, 5, 6. You could do 1, 2, 3, 4. What you are doing with pain and light touch is your patient's going to have their eyes closed. You're going to have something sharp and something dull. You're going to tell them this is sharp and this is dull. So let me know the location and what you're feeling, the sensation. So go ahead and close your eyes for me, and I'm going to start. You can see this on the neuro assessment in my YouTube videos. I do this. So you're going to have to close your eyes, and you're going to poke sharp right upper forehead, dull left upper forehead, dull left cheek, sharp right cheek. So you're going to go through and test all that, because that's, again, if we're assessing if a patient has a stroke, this is the assessment that we're going to do, a neuromuscular assessment. And so we want to determine, is their right arm totally numb? We need to know, can they feel anything? Because if they can't, what could that be at risk for? What if they couldn't feel anything at all? Okay, well, they're at risk for a stroke. What if they already have a stroke? What are they at risk for? Skin damage, right? So if they can't feel that there's something sharp pushing up against their skin, that's a problem, because that could cause them to get stabbed, cut on accident. We have no idea. Yeah. Is there something? No, I'll show you some in the lab. Usually I break apart tongue depressor or a popsicle stick. I break it apart and there's a sharp side or a dull side. There's a couple other things in the lab that I can show you to do sharp and dull.
So I would.
Yeah.
I would say like elbows.
This is the checkers game.
I'm listening.
Contour. Color normal.
Yep. Color is normal. Color is appropriate. Here, I'm going to show you my video because my video has all that in there.
Shoulders, elbows, wrists, hands, ankles, feet, knees, hips, and spine. I'm going to be inspecting and calibrating the size, contour, texture, color, skin, muscle, range of motion, strength, and confidence. So first, I'm going to start with my patient's shoulders.
So I don't have head and neck in this, but
symmetrical.
so contour kind of goes along with symmetry. Contour.
No crepitus noted. The color and skin of my entire patient is even and intact, and it is appropriate for patient's ethnicity.
So I could say that as a general statement for everything.
Send your elbows towards you, away from you, and go ahead and pull your arms into against my hands. That way, testing for strength. Next, I'm going to assess my patient's wrist. Again, noting the color and the texture of the skin. On inspection, location, strength, tenderness.
Adequate strength, yep.
Go ahead and rotate your wrist for me. Pull towards you with my hands and pull towards you with your wrist. Like that, your wrist. And then press again. Testing for strength. You can wiggle your fingers for me. Make a fist. Straighten your hand out completely. Again, no noted pain or tenderness. Next, I'm going to move to the knees.
So I guess I do hip and spine next.
The color is appropriate. Any pain or tenderness going to help you here. You can go ahead and actually sit up on the stretcher for me. I'm going to have you
Press both of your legs towards me. Pull back. Resting for strength. If you can extend both of your legs for me and then retract them. Any pain or tenderness. Next, I'm going to assess my patient's ankles. Again, knowing that the color is appropriate, the skin is intact, there are no lumps or ecchymosis noted, no swelling, no tenderness upon palpation. Can you rotate your ankles for me? And can you pull back against my knee? And again, no crepitus noted. Shoes, if you go ahead with your feet to toes for me.
Fingers.
It
started.
Lastly, I'm going to assess my patient's hips and spine at the same time. You can go ahead and stand back up for me. If you could turn away from me, or I can assess your hips, any pain or tenderness here. And if you could go ahead and bend at your hips. I'm also looking at the spine to make sure that it is aligned midline in the back, in the patient's back, to be sure that there are no signs of scoliosis or lordosis, and if the patient has proper alignment of the hips and appropriate motion. Go ahead and get back up. And that is the end of musculoskeletal assessment.
So now it's neuromuscular, which is incorporating in the neuro assessment on again, on YouTube videos or the ones I just showed you. You would have done patellar and tricep reflexes, and then the pain, the light touch, and the dull. So if you guys want to head on over to the lab, we'll meet you over there. You guys can practice. Maybe bring your validations, partner up. The whole point of this is for you guys to practice your musculoskeletal assessment.